Afternoon. Today we talk about the right ventricle, the right atrium, pulmonary pressures, right atrial pressures, tricuspid valve. So the whole right side of the heart, how it is imaged. Sort of easy crowd to preach the importance of the RV2. As you know, it's affected in many cardiovascular diseases, can account for the presence of shock and hypotension, which is not uncommon in the post-op setting, for example. When you look at patients with congenital heart disease, the right ventricle not infrequently becomes the focus of what is going on and can determine or help the cardiologists reach decisions about how to proceed. Outcome prediction has been shown in many settings with acute MI, patients with HFrEF, HFpEF, valvular heart disease, and cardiomyopathic disorders. In echocardiography, we have 2D and we have 3D. 3D is making its way still, so we depend a lot on 2D, which means you want to image the RV in multiple views and then put things together. Not infrequently, because our techniques are and our planes are not perfect and not necessarily the same for every patient and not necessarily the same when different sonographers say tackle the same patient. One has to put things together from the different views before reaching a conclusion. It is not looking at one view and then making a determination. So the very first view we use is the parasternal long axis view, and obviously you recognize the LV structures. The importance here is for the RV anterior wall. That's the first time we look at the RV in the course of the routine exam. And it can give you a sort of you can say a rough figure or a rough estimate of what you expect the RV size to be. Is it going to be normal, enlarged, or not? Because here we can measure thickness with the axial resolution, the guidelines have emphasized using this view to measure the anterior wall RV thickness. Having said that, it is much better seen in the subcostal view, and it is the view that one should use if you are interested in RV wall thickness. Why do you care for RV wall thickness? If you're looking at RV dysfunction and enlargement, the presence of increased wall thickness favors the presence of chronic disease as opposed to an acute rise in PA pressures. In this view, you can measure the RV outflow tract in that area, and that dimension has been used to diagnose patients with arrhythmogenic cardiomyopathy, formerly referred to as arrhythmogenic RV cardiomyopathy. The magic number you need to remember is 33 millimeters. It is expected that physicians with special training and expertise in cardiovascular imaging will know several of the measurements that we will go through today. Then we are still in the parasternal parasternal window, and we get another view that can show us in a long axis the RV outflow tract, the pulmonic valve, and the beginning of the pulmonary artery. You can align with flows here, and you can examine what is happening in the infundibulum, say in someone with infundibular stenosis. In the RV inflow view, still the parasternal long axis view, you get to see the RA, you get to see the anterior wall of the right ventricle, you get to see the inferior wall of the right ventricle, the anterior posterior tricuspid PAP muscles, and then the anterior and posterior leaflets of the tricuspid valve. You will see the TR if present. So this is a view when we are looking for patients with tricuspid valve disease you want to pay close attention to. Also, when you look at patients where you get patchy involvement of the right ventricular function, as for example CAD or arrhythmogenic cardiomyopathy, you want to carefully scrutinize the different walls. We have the parasternal short axis views at the level of the aortic valve, and in that view you have the RA, the LA, the interatrial septum, so a chance to interrogate the interatrial septum and flows and the motion of the septum. You have the septal and anterior leaflets of the tricuspid valve, another opportunity to interrogate the tricuspid valve with color, very important. And you also get to see the pulmonic valve, the RV outflow tract area. You put color to look at the flows here and interrogate RV outflow tract by pulse wave and continuous wave Doppler. If you angle a bit superiorly, you are able not only to see the RV outflow tract and the pulmonic valve, but also the main PA. This is the view if you are going to do PA measurements you want to use, and you can see the bifurcation of the pulmonary artery. The yield of this view is higher in children than in adults. Then we have a series of short axis views at the level of the mitral valve. It gets you the right ventricle here and the left ventricle and the mitral valve. This particular view gets you different parts of the right ventricle. So grossly, you look at it for maybe the RV is enlarged or not enlarged, but as far as segmental function assessment, not reliable. You get the anterior, you get the lateral, and you get the inferior walls of the right ventricle. You can also do the level at the papillary muscles, and that will get you a more distal cut of the RV. In these views, the RV has a crescent shaped. In the older literature, when people were interested in using 2D models to get LV volumes, these areas could be tracked in end diastole, and with mathematical manipulation of the expressions, you can do RV volumes. Nowadays, this is not emphasized. Apical four-chamber view is the view that is recommended to look at RA size and RV size. For the right atrium, we measure at end systole. This is the time when the right atrium is maximum. So we have a long axis measurement from the roof to the level of the tricuspid valve. The upper limits of normal is 5.3 centimeters. Then you have the minor dimension that is supposed to bisect that long axis halfway through, and you would get a maximum measurement of 44 millimeters. For area, it is 18 centimeters squared. If you go with RA volumes, with the 2015 guidelines, the upper limits of RA volume for women is 33 ml per meter squared, for men is 39 ml per meter squared. Keep these different cutoffs when you are looking at RA volumes and drawing conclusions or comments in your report about RA size. It is not the same as the LA 34 ml per meter squared across the board. Probably more accurate also for the LA to be thought of this way, but that's where the guidelines stand. When you look at the right ventricle, you are able to see what is happening with the free wall, if you can. Sometimes the use of contrast for one reason or another can help you visualize the RV, and then we have other views that will show you more of the RV free wall. You get to look at the tricuspid valve, interrogate the tricuspid valve, color Doppler, look at the interatrial septum as well. This is the view that we depend on to get Tapse and to get the S prime tricuspid SM velocity as indicators of RV systolic function. If we angle a bit anteriorly, you get more of an RV-focused view. This is an useful view that shows you, as you notice, compared to the apical four-chamber, more of the RV free wall. These views become very critical when you are suspicious of right ventricular disease. But also sometimes we go into an exam and we do not know what is going on, and you may uncover that the RV is central to the problem you're dealing with. And so sonographers should aim to get these RV-focused views as well. These are the views that you want to trace end diastolic and systolic area of the right ventricle and therefore obtain the fractional area change. We'll talk about that briefly. Again, similar to the right atrium, the upper limits of normal for the RV end diastolic area vary by sex. So for men, more is allowed than for women. It's 12.5 centimeters squared per meter squared. For women, it is 11.6. Another view that is also helpful, the guidelines refer to it as a modified four-chamber view, is really a low parasternal position, and that gets you a nice look at the RV and the RA. You can tell that the RA here is looking oblique and not infrequently foreshortened. So you do not depend on this view to do RA volumes. But this is very nice look at the tricuspid valve. You can look at the interatrial septum. Someone with a suspicious ASD, this is an excellent view. You get to align with the tricuspid inflow, pulse wave Doppler, TR jet, all of that useful here. And also useful to look at the RV free wall. Sometimes, say, patients with arrhythmogenic cardiomyopathy, they have these focal areas which may be akinetic, dyskinetic, or even aneurysmal, and unless you put several views together, you can miss them. So look carefully at these images. To visualize the moderator band and more of an anterolateral wall, there is a 5-chamber view that brings in the RV. Again, you have the tricuspid valve. So numerous opportunities, as you've seen through all the views, to look at the tricuspid valve and tricuspid regurg. Not a view, however, recommended for RV size assessment. It's the apical 4-chamber and the RV focused views. If you angle posteriorly, you get the posterolateral wall, and again looks at the tricuspid valve, and here is the coronary sinus. Subcostal views, this is the view you want to rely on for RV wall thickness. It's a chance to look at the interatrial septum, to look at the tricuspid valve. If there is pericardial effusion, compression of the RV, this is a very important view you want to focus on and plan on. Sometimes we see patients with obstructive airway disease, no good parasternal windows, but you can do a solid exam, solid in that it gives you a feel for, say, LV function, not necessarily details of accurate size quantification, and it also is a view that can get you the pulmonic valve, RV outflow tract. You can get very solid sampling with the flow here with pulse wave Doppler, so remember that view as well. This goes over the blood supply, and it is expected also that physicians reading echocardiograms know the blood supply of the right ventricle. So it comes from the right coronary artery, and the acute marginal branch of the right coronary artery supplies the anterior wall of the right ventricle. The posterior descending coronary artery supplies the inferior wall as well as the posterior 1/3 of the interventricular septum. Distal septum and apex of the RV are supplied by the left anterior descending coronary artery. So someone with an myocardial infarction in the territory of, say, LAD distribution can get apical RV problems. The moderator band, however, gets its blood supply from the not the posterior, but the anterior septal perforators, something to keep in mind when patients are going for alcohol septal ablation. In about 10% of cases or less, the posterolateral branches of the circumflex coronary artery can contribute to the blood supply of the inferior or posterior wall of the RV. So the RV may be involved in patients with lesions in this artery. Then there is the conus branch that supplies the infundibulum. In about 30% of cases, it has a separate ostium from the RCA. For those who do cath, I don't know how frequently it is to get in that artery, but it's a very small artery if you inject in it enough to trigger ventricular arrhythmias, bad arrhythmias. Okay. You want, if going for RV thickness measurements, you want to go to the subcostal view. You want to zoom, you can use 2D, you can use M mode, and you go ahead for that measurement for wall thickness. And in the apical 4-chamber view, we can get several measurements to assess RV size, the base, the mid-level, and the long axis. The basal diameter, the upper limits of normal, 41 to 42 millimeters. Again, probably more accurate if you index that to the size of the individual. The mid-level, which is halfway through the RV, is about 35 millimeters. The upper limits of the normal long axis is 83. That obviously depends on whether you are able to visualize that whole long axis of the RV or not. That was in millimeters. Fractional area change is something similar to the ejection fraction concept in terms of what it reflects. Its limitation, as you can tell, is it's getting just part of the RV. The RV is not just what you see in that apical 4-chamber view. Having said that, several studies have looked at its correlation with ejection fraction with CMR and have reported acceptable correlations anywhere from 0.5 in some studies to probably low 0.7s in others. Sometimes you will see discrepancies when we look at the RV function based on fractional area change compared to long axis motion, and there can be reasons for that. Could be disease that limits certain segments of the right ventricle, could also be related to rotational movement of the heart. So what other indices are there? By the way, the interest now in indices of RV function is rising again because you're looking at more patients with tricuspid valve disease that may be considered for interventions and for surgery. And similar to the mitral valve, when you operate in someone with mitral valve, say severe mitral regurgitation and ejection fraction of 50, you can predict that the chances of a post-op LV systolic dysfunction is higher. The same concept likely applies on the right side, albeit we do not have a concrete measurement that has gained acceptance and experience as the ejection fraction on the left side. So people have looked at other indices. One of these is the rate of rise of RV pressure during systole. If you have a high fidelity pressure catheter, you can look at the pressure changes with time during systole and during diastole. And so a normal contracting ventricle will increase its pressure faster than a ventricle that has contractility problems. As you know, the TR is a reflection of the pressure gradient between the RV systolic pressure and the RA systolic pressure during systole and then during diastole. So if we know a change in pressure and we divide it by a change in time, we have the dPdt value, millimeter mercury per millisecond. The guidelines advocate for a 2 meter per second and a 1 meter per second velocities. 2 meter per second, if you apply the modified Bernoulli expression, the 4v squared is a 16, the 1 meter per second is a 4, so therefore your numerator is 12. If you always choose these 2 points, your numerator will be fixed at 12. And then all you have to do is figure the time between points 1 and 2, which is here shown as 3. That will be in milliseconds. And then you convert it to seconds. The problem, as you would expect with this measurement, lies in this time point. Having said that, some investigators have reported that this appears to be a promising index of RV systolic function. And the normal cutoff is around 400, 430 millimeter per second. Word of caution, similar to EF, similar to fractional area change, similar to Tapse, similar to strain, dPdt is not only a reflection of contractility, but also preload and afterload. Then comes the myocardial performance index, which is also acknowledged in the guidelines, and you can acquire that by pulse wave Doppler as well as by tissue Doppler at the lateral side or at the tricuspid side of the tricuspid annulus. The advantage of the tissue Doppler is it's the same cardiac cycle and it's one position and you are done with it. And so if we start by the easier one, the way it is calculated is the sum of isovolumic contraction and isovolumic relaxation time divided by ejection time. So here they say the ejection time is the duration of that systolic ejection velocity, and you have the isovolumic contraction time before it and the isovolumic relaxation time after it. You measure these time intervals directly and you are done. For pulse wave Doppler, we do not record tricuspid inflow and RV outflow tracked systolic velocities in the same beat. So you will need different beats, which means you are more accurate when you look for matching RR intervals. And strictly speaking, it's the time between the end of my tricuspid A velocity of one cycle to the beginning of the tricuspid E velocity of the second cycle. That total time equals the isovolumic contraction time, ejection time, plus isovolumic relaxation time. And so you get the ejection time from the RV outflow tracked velocity, and you subtract the ejection time from the total time interval above, and that gives you the numerator. Another approach is if you have tricuspid regurg. Tricuspid regurg takes place during isovolumic contraction, ejection, as well as isovolumic relaxation. So you get the total duration of TR, and you subtract from that the ejection time to get the numerator of the expression. The upper limits of normal is 0.43, and the upper limits of normal for the tissue Doppler method is at 0.54. One of the critiques that you can tell for this index is it is not only a measurement of isovolumic contraction and ejection time. These are events that take place in systole, but also isovolumic relaxation time. And so if someone has a high right atrial pressure and RV systolic dysfunction, the isovolumic relaxation time can be shorter, which means a smaller numerator, which means a smaller value of MPI that may not cross over to the abnormal range. So for most labs, this is not done. Perhaps for research studies, it could be a value in the search for simpler indices of RV function, but is not really a pure index of contractility. Then comes Tapse, and some are very fond of Tapse. I'm sure all of you have seen cases of pulmonary hypertension where Tapse appears normal and things are clearly not good for the right ventricle. And some have looked into this and said, why could Tapse be normal when function of the right ventricle is abnormal? Part of the reason the motion is taking place is not simply the lung axis function of the ventricle or the subendocardial fibers contracting, but also a rotation. And that component of rotation may contribute to a higher value of Tapse. The cutoffs in the 2015 guidelines is a 17 millimeter. Less than that is not good. More than that, you are willing to pass. I mean, the way I would look at using all of these indices, at the end, you are looking at the indices and using your own judgment and conclusions. Of the three, the tricuspid S prime that is shown here, the Tapse and the fractional area change, probably the most accurate of the three is the fractional area change, provided you see the endocardium well. The upper limits of the S prime velocity is a 9.5 centimeters per second. If you want to remember round numbers, say 10. In the older guidelines, it was 10. In the newer guidelines, it's 9.5, not a big difference. Nobody uses color-coded tissue Doppler, but I put it here to make you aware that this is a mean velocity, so usually 20 to 30% lower than one you get by pulse wave spectral Doppler. Then comes strain, and this is an early validation study where strain was measured by tissue Doppler. We no longer use tissue Doppler because it takes a longer time and is demanding technically and also lower reproducibility. Again, sonomicrometry is showing good accuracy. Since then, we moved to speckle tracking. We'll come back to that. Then comes 3D of the right ventricle. 3D of the right ventricle has been validated, or should say compared against CMR, and has shown acceptable correlations with CMR in terms of values, okay? Again, a lot of the work depends on how you measure things. At the end, when you look at different studies, you have to see what patient populations got you there, what sort of right ventricles. If you have really bad 2D images, it is hard to imagine that 3D will make something better. The upper limits of normal for 3D RV volumes also depend on the gender of the subject. So for men, it is 89 mLs per meter squared. For women, it is 74, and systolic volumes for women, 36, for men, 44. In the older guidelines, a 44% was taken as the lower limits of normal. In the 2015 guidelines, it's 45. The main advantage of 3D RV volumes is it takes into account the whole right ventricle and not what we were looking at, compartmentalizing things from different views. I've seen 3D with some publications where you can tell that the volumes don't even make sense when you put them in perspective to the size of the patient. Now we look at strain with speckle tracking. There are two softwares now that are dedicated for RV speckle tracking strain, and there is one where the system treats it as though it is an LV, and then you can put things together and say it's really RV, you know what you're doing. You can do the RV free wall and you can do the septum. Because the septum is shared by the LV, if you want a more pure measurement of the RV, one would think the RV free wall is where you should go. There are few studies like 5 studies or so that have been published showing that RV free wall strain is a better prognosticator of outcome than the strain involving the septum as well as the RV free wall. And the upper limits is at 20%. Ignore the negative number when we're talking with strain, so a 21, a 23, a 25 is a better performance. RV strain and strain in general is an indicator of contractility, but is also affected by preload, by afterload. For strain, heart rate, technical quality is very critical as well. So that's a summary for many of the measurements we talked about. The ones we haven't talked about are the diastolic measurements. Here you want to look at the tricuspid E to A ratio, and you want to average a number of beats because they vary a lot with respiration. So either end expiration or you're averaging at least 5 beats. A ratio less than 0.8 or more than 2 is considered abnormal. A tricuspid E to E prime ratio more than 6 will come to that, and a short decel time or one that exceeds 242 milliseconds is abnormal. Very seldom people have delved into RV diastolic function. Most of the diseases that involve the right ventricle, they affect both functions as opposed to isolated diastolic dysfunction. PA pressures, the older definition is on that slide, 25, based on the mean PA pressure by cath. Now it's 20 millimeters mercury. And if we are interested in saying, is this a disease due to the pulmonary hypertension of the pulmonary parenchyma or of the pulmonary vasculature, so groups 1 and group 3 pulmonary hypertension as opposed to group 2, you need to show that the wedge pressure or EDP are not increased. The magic number is 15, and pulmonary vascular resistance is increased. From an echo point of view, then you say, I want to be able to say what the mean PA pressure is. I want to be able to say, is this something, the wedge pressure is normal or not, and PVR is increased or not. So these are laudable goals to achieve. And when someone has pulmonary hypertension, the size of the RA, the presence of pericardial effusion, the size and function of RV carry prognostic information. PA systolic, we get TR by multiple windows. We need RA pressure estimation, so we need subcostal views for IVC and hepatic veins. If this is a case, referred to the lab with a diagnosis of pulmonary hypertension, or the physician says, I want PA pressures, we have to use saline contrast if the patient agrees to IV and injection. And the good news is the feasibility is pretty high of TR when you have pulmonary hypertension. Low TR feasibility is usually in people with normal PA pressures. And again, we have to put things together. So when you see a D-shaped septum, systole, and diastole, that tells you mean PA pressures is up, you cannot report a PA systolic, say, of 30 millimeters mercury. Doesn't fit. Bad jet, incomplete, not useful. You can give contrast, and we apply the modified Bernoulli equation, as you all know before. PA diastolic is another piece. Probably the feasibility of PA diastolic estimation is much lower than PA systolic, though where labs look for it routinely expect the feasibility to be higher. We mentioned several views in the parasternal short axis and also in the subcostal where you can get pulmonic flow and PR jets. We still need RA pressure estimation, and the feasibility is more than 70%. The velocity that we are interested in is the end diastolic velocity. We apply the modified Bernoulli equation. And when you look here, the RA pressure carries a big role in the estimation of PA diastolic pressure because the PR and diastolic velocities are small. So if you have an incorrect estimation of RAP, that can affect adversely the correct estimation of PA diastolic pressure, and that is one of the main critiques for relying on PA diastolic pressure non-invasively as a surrogate of wedge pressure. Mean PA pressure, similar to the systemic pressure. If you know the diastolic pressure and you know the pulse pressure, then you know the mean PA pressure by that expression. Needless to say, you have several measurements now. You need RAP, you need TR, you need end diastolic velocity. So each one of these comes with its errors. A direct approach is using the peak PR velocity with or without adding RAP. When someone has a normal RV diastolic pressures, normal RV function, it is okay to ignore the RAP. But when someone has diastolic dysfunction of the right ventricle, high RV diastolic pressures, the estimation without it will be an underestimation. People advocated over the years the acceleration time and have used it either indirectly, just a short acceleration time means a higher PA pressure, and some have used that expression. In general, a cutoff of less than 100 milliseconds is what is considered short. Being a time interval, it depends on the heart rate. It can also vary between children and adults. And this expression may need a different slope if you are looking at faster heart rates than slower heart rates. One particular group advocated the reliance on the TR time velocity integral as a surrogate of mean PA pressure to which they add RA pressure. This has been of interest more recently, and some have reported better correlations with that. The last expression that you see here is simply a regression equation that says patients with a higher PA systolic are more likely to have a higher mean pressure, which makes sense. Whether this slope and that intercept hold across the board has not been looked at critically. That's the example of looking at the peak PR velocity. Pulmonary vascular resistance, the actual expression in the cath lab calls for getting the mean PA pressure minus the mean wedge pressure, and you divide that by the cardiac index. Dr. Schiller and his group advocated sort of summarizing this approach and said, let's use the TR peak velocity as a surrogate for that numerator. You can see that the peak TR velocity is very far from the other items that were needed. It's not the mean pressure, and it doesn't account for the wedge pressure. The time velocity integral of the RVOT is used in the denominator as a surrogate of the cardiac index, and you can tell that for that also you need the RVOT diameter. Sometimes you have a large diameter and a small TVI, so you end up with erroneous conclusions. Having said that, it was used and it was looked at as a predictor of outcome. If you look at a ratio more than 0.38, it is very specific, but look at the PVR, more than 8 Woods units. This is in the dangerously elevated zone. In the less than 0.12 to 0.15, they usually have a normal pulmonary vascular resistance, and a cutoff more than 0.15 was predictable of heart failure hospitalizations and all-cause mortality in the heart and soul study. Most labs do not use PVR, and the guidelines do not endorse calculating PVR across the board. Where thinking of PVR can be of value would be in athletes, probably with exercise. The PA pressure is dependent on flow and resistance. And so if you have a very large flow into the pulmonary circulation with a PVR that is normal, the PA systolic can rise to even 55 and 60. This is not the same as someone who, say, at a low level of exercise where their cardiac output doesn't increase much, and they end up with that same value of 60 millimeters mercury. RA estimation based on IVC of value in someone who's not on mechanical ventilation, and if it's dilated and non-collapsing, that's the highest RA pressure, and you see the examples in the upper panel, normal, in the lower panel, everything dilated, including the hepatic veins. Of value in patients who are not on mechanical ventilation, the less the collapsibility index, the higher the RA pressure, the lower the collapsibility, the higher the collapsibility index, the lower the RA pressure, the lower the index, the higher the pressure. What you see as the open circles are patients who are on mechanical ventilation, and it's a scatter plot. In these patients, the main value of the IVC is if it is not dilated. If it is not dilated and, say, spontaneously collapsing, you're sure RAP is normal. But if it is dilated, they are not automatically with increased RAP. One thing that we've asked for is if you are scanning a patient in the ICU and they have an RA pressure catheter, it's a good idea. You can include that as part of the report, and then whoever is reading can add that value without having to estimate. The guidelines actually say that is okay. Also, if you say you are examining a patient and you're scanning them and you're looking at their neck veins and you're able to estimate their RAP, it is also okay to use that. At the end, we are using the RAP to estimate PA systolic pressure, PA diastolic, PA mean, so getting that piece of the equation correct will also do well for the other pieces. The challenges are in patients with respiratory distress, mechanical ventilation, and we talked about that issue. And of course, if somebody says post-op and there are no subcostal views, you can look at the tricuspid inflow and the hepatic veins the same way you look at the mitral inflow and pulmonary veins to draw inferences about pressure. Higher E to A ratio in diseased hearts, short decel time in diseased heart, short acceleration time in diseased heart, all go with increased RAP. The predominant flow in diastole is seen in patients with elevated RAP. Again, we're not talking about normal young subjects. Normal young subjects, this is what you see. Not infrequently, you can record a brief mid-systolic flow. This is not pathologic. And then the atrial reversal during late diastole with RA contraction, that's an indicator of late diastolic RV pressures. Examples for tricuspid inflow from different groups is shown here. The signals do need, you see some feathering, and they need some adjustments in terms of going down on the filters and going down on the gains as well. That's a publication from '96 showing a significant correlation, but you can see wide scatter between the tricuspid E to A ratio and mean right atrial pressure. Hepatic veins did much better in terms of predicting mean RA pressure and are recommended in the guidelines. Predominant flow in systole goes with normal RAP, equal flow somewhere between 5 and 10, and here because of the variation, we want to look at end expiration or average number of cycles. And the magic number, if you use the time velocity integral, is a ratio of the systolic time velocity integral to total flow of less than 55% to identify elevated RAP. As I just said, you can look at it visually. You do not need to do measurements or calculations. Prominent A reversal in someone with elevated RV and diastolic pressure is nicely shown here. The systolic reversals, we'll talk briefly about them with significant TR. Notice the extent in terms of a TVI as well as the duration of that systolic reversal, very different from the brief mid or end systolic flow that you may see. Limitations of hepatic veins are in patients with pericardial compression syndromes, tricuspid stenosis, severe TR, arrhythmias, heart transplant recipients sometimes, and absence of subcostal views. Similar to the mitral E to E prime, there is also a tricuspid E to E prime, and you can also measure the time between the end of systolic ejection and the beginning of the E prime. This time interval is referred to as isovolumic relaxation time, and the shorter that time interval, the higher the mean right atrial pressure. Example for tricuspid E to E prime and its correlation. Importantly, this is a group of patients unselected. This is a group of patients with pulmonary hypertension showing very decent correlations between the tricuspid E to E prime ratio and mean RAP, and also that 6 cutoff that we talked about predicting outcome in that patient population. Okay. You see, we have a lot to share. These are limitations for the E to E prime. Let us flush then through the tricuspid regurg, which is a story by itself for us. Quick clues about RA. When you think of TRs, think about it along the same lines of MR. You need to look at the tricuspid valve, the RA size, RV size, RA pressures, tricuspid inflow, hepatic veins, and so on. Where there is 3D, we'll skip that. 2D findings are very important and not to be ignored. You look at the Pisa radius at an aliasing velocity of 30 to 40 centimeters per second, smaller radius, less TR, larger radius, more TR, vena contracta, same concepts as mitral. The magic numbers 0.3 centimeters and 0.7 centimeters, jet area less than 10. more than 10 and less than 5 for severe and mild. We'll not talk about vena contracta or PISA. That's the approach of PISA, an example from the guidelines. But a word of caution about PISA and quantification. The guidelines were based on a study that used correcting factor, a correction factor to avoid underestimation of the actual volume of the tricuspid regurg. It will be more accurate. CW Doppler, no direct relation between peak TR velocity and severity of TR. Some people think with severe TR, if I have a high TR velocity, that's severe TR. Not correct, probably the other way around. Then we have this V-wave signal and very small RVRA pressure gradient, and we looked at the systolic reversals. We can talk more. We'll let Dr. Yang give you his perspective.
Very elegant and comprehensive coverage of echo and echo first, of course. Let's see. Okay. And can we switch over to my laptop? And I get to take you guys on a whirlwind tour through cardiac MRI. Let's see. Do you have quick share or? We don't have quick share. Well, they don't have. Okay, well, while he's getting us set up, I'm just going to breeze through the first two parts of my slide set. Basically, first, why cardiac CMR? And in the case of cardiac CMR, I'm not going to beat to death the fact that we have a limited field of views. We don't use any radiation whatsoever, and we can actually get a full comprehensive reproducible assessment for serial comparison of the right ventricular volume. In fact, formal studies that have been done on this have shown that there's good inter-reader reproducibility of this technique, and this allows for serial comparisons as well. Initial work showed a high coefficient of variations, about roughly 8 to. We had it. We will turn. Roughly about 8 to 10%, but that has since come down to 5 to 6% with improvements in the technique. How do we do it? How do we do it? What we typically do is, so just skip these slides. What we typically do is we acquire our normal short axis stacks, go through, get our LV stacks as well. And then the nice thing about cardiac MRI, and 40CT can also do this, but at the cost of additional radiation and the need for contrast, we can also get 3-chamber RV, 2-chamber RVs, and RVOT views as well. Let me skip through this, but this is just examples of visual assessments showing severe RV dysfunction, severe RV dilatation. You can even see septal flattening and RV hypertrophy as well. And as Dr. Nagueh did allude to, although we don't see formal hepatic venous return, we can actually see hepatic venous reflux when we do the arterial phase of contrast. And so when you do CT and MR, the fellows, please pay attention to that, because that can indicate increased RA pressure or severe or significant tricuspid regurgitation. We use the Simpsons method where we do serial stacks and then sum up the area, multiply by the thickness, and get the volume that way. And we also have the added advantage of doing phase contrast imaging as well, getting a flow volume assessment as well to corroborate our measurements within the RV, assuming no significant valvular regurgitation. Does it matter whether or not we do axial versus short axis? Turns out not really. You can actually do both, although we prefer to do short axis stacks because at our center here, because most people are familiar with that. However, there is one special case where it does have its advantage, and we actually had a case yesterday. Our congenital CMR attending Valeria Duarte had an Epstein's case where we did find that it was easier to trace the boundaries of the tricuspid valve. So in the ACCHA 2018 guidelines, CMR is reasonable for Epstein's anomaly for looking at RV volumes and systolic function. So why does it matter? It turns out in patients with elevated pulmonary pressures, it's not those with preserved RV ejection fractions that don't do poorly prognostically. It's those who have low RVEF, and it's shown here, as you can see in group 4, those who have poor RV systolic function do worse. And just to fly through some cases, if you look at this, is a 66-year-old male admitted with chest pain. You can immediately appreciate that the RV is not moving quite well. In fact, there's some regionality to it. You can even see there's a hint that the inferior wall might not be moving so well. And in using LGE, we can see there's scar enhancement, not only of the inferior septum, but also of the RV wall, indicating RV infarct. Okay, and just flying through it. And if you do detect RV infarct, this does have a prognostic significance. It does impact six-month mortality on these patients as well. This is a 61-year-old female who came in for PVCs, and the thing you'll appreciate is the RV is kind of a bit sluggish, and more importantly, you see this big outpouching here, indicating regional RV dyskinesia. So this patient actually fulfilled 2010 task force criteria on CMR for depressed RV ejection fraction, regional akinesia, dyskinesia, indicating that this patient has ARVC. This led to her entire family getting screened as well. And these are just the formal criteria, which I won't belabor right here. Another issue that often comes up in the CMR world is whether or not chamber enlargement is significant. And this is actually one of our former fellows who was participating in a volunteer scan. One thing you'll appreciate is that the chambers look a bit more generous and his volumes were actually measured as normal. But keep in mind, his heart rate was like in the 40s, 50s. So this is just an example of athlete's heart. Where everything was still preserved. LA and RA were normal sized. Okay. And then this is a nice oldie but goldie, 67-year-old female with liver cancer referred for valve assessment. One thing you'll appreciate is that the RV is big, and most importantly, you'll see that the tricuspid valve is fixed. So this is a very classic case of a carcinoid syndrome. Okay. So we get one of these every now and then, and it becomes clear that they have raging TR, and we're asked to quantify this. Speaking of, we quantify it similar to MR in the CMR world. We take the RV stroke volume and then take the PA systolic flow, and the difference between that makes up for the regurgitant volume, regurgitant fraction. One group did publish using a quote phase contrast vena contracta, so kind of equivalent of looking at the vena contracta on echo, but using two CMR techniques for determining TR severity. Our very own Yang Zhan actually published whether or not the severity of a TR had any significance, and he presented this in the Canadian Society of Echo and also participated in a young investigator competition for the ACC a couple years back, doing very nice work, and we're looking forward to the publication sometime. Congenital abnormalities also come through. This is a patient I actually saw in clinic, had repaired tautology of Fallot by Dr. Cooley next door, and she came in with some dizziness. And one thing you'll appreciate is on the RV3 chamber, there's actually signal dephasing in diastole, both in the RVOT view and RV3 chamber view, indicating significant pulmonary regurgitation. This was quantified as moderate to severe. Okay, so in an adult congenital world, this is actually recommended for, CMR is actually recommended for quantitative assessment in these kind of patients. We'll belabor this. Okay. And last but not least, Dr. Nagueh presented elegant information on assessing pulmonary hypertension using echo. Here's a very nice example of a patient who had confirmed pulmonary hypertension. One thing I also included here was enlarged PA. Keep in mind that this is sensitive for pulmonary hypertension, but not specific. You can actually have PA dilatation for any number of reasons: high flow state, aneurysmal PA as well. So it's not specific to pH. And keep in mind, as Dr. Nagueh pointed out, it's actually more a hemodynamic assessment where you have to have the mean pulmonary pressure according to the 6th symposium, World Symposium on Pulmonary Hypertension. They actually agreed on greater than 20 millimeters of mercury on the latest meeting last year, in addition to pulmonary capillary wedge less than 15 and PVR Woods unit greater than 3. Okay. One thing that we often observe is also the geometry as well, and some people have looked at whether or not this allows us to infer mean pulmonary pressure as well, although this isn't widely applied. But this is a potential option, not only in the CMR world, but in other modalities where you can see the angle with different cardiac phases. Okay. As far as future directions, there are ongoing advances in trying to do parametric imaging techniques where we can look at the different properties of the tissue. One group in Virginia has actually come up with a 3D parametric mapping technique that may allow us to look at the RV in further detail, the Angie sequence, and so that's one thing we're looking forward to. There's work also using feature tracking where you can actually track the RV free wall and get strain measures as well. Although we don't have anywhere near the temporal resolution of echo, we can still get that information as well. And last but not least, there's 4D flow. This is courtesy of Huey Lin, one of his patients using a patient that was imaged here, showing the different the flow properties that can be acquired and characterization that can be done. So in summary, CMR does provide excellent visualization of the RV with accurate assessments of volumes and function. It has low variability, which allows for repeatability and serial assessments. It permits assessment of RVMI and also in the future more tissue characterization. And new techniques are actively being investigated, potentially expanding the utility of CMR for RV assessment. Thank you for your attention. Any questions?
We've not seen any 3D displays like CMR. You do not rely routinely on it. Is that right?
Everything is based on 2-day CNI techniques. There is ongoing work with compressed sensing, though, to try to get 3D acquisitions, but that's still work in progress by the physicists.
Are you talking about just 3D displays?
So I get for you when you are, the main advantage of a 3D display is it shows you all parts of the right ventricle together, and it may be easier to appreciate regional dysfunction, say, right away if you have a faithful 3D display of what is the ventricle looking like. For us, that hasn't been looked at by echo. We rely a lot on the tomograms from different views. So I was wondering if you guys do that, when do you resort to it, if you do?
I mean, to a large extent, it's just a post-processing technique. So you could basically contour each individual slice, and then if you had a post-processing tool that could basically just generate a 3D shell for you, that's feasible and doable. I guess I just don't know how that's going to add more. Because again, all of this is just a post-processing.
We actually do have that visualization techniques with some of our post-processing software. It does let us see the 3D volume as it's moving.
And the feature tracking strain that you measure, in which direction or which strain are you measuring?
Typically longitudinal. That's what's commonly reported in literature.
You can visualize, I take it, RV clots and masses and all of that if you use contrast.
Yeah. I mean, for visualizing that there's a mass present, you don't need to use contrast for that. But to characterize it, to say, is this thrombus versus is this a malignant tumor, for that, giving contrast adds.
Yep.
Do you include routinely in the CMR reports I've seen, we see RV volumes and EF. Do you measure RV wall thickness routinely or no?
We report RV wall thickness, is normal, mild, moderate increase. Again, using a cutoff of 4 millimeters as the upper limit to normal. In a particular case where there was an abnormality, we will typically measure the thickness to determine if it's mild, moderate, severe. Yep. And I think usually we'll report the value in the free text, but we don't have that as one of the fields in a discrete field for that.
Any other questions?
So you had somebody with a heart rate of 40 who worked here? Okay.
There's lots.
I won't reveal names.